So essentially, I'll give you the example of the latest finding, the paper that we published, in which we show that if you make hypertension by having excessive salt intake, you can induce dementia. And that's shown in humans as in animals, all right? Excessive salt is a hypertension caused by salt increase can lead to cognitive impairment. And in this study, we found that, what goes on when you have the salt into your system is that there is something going on in the gut that leads to, the gut is probably the largest immune organ in the body. So there are more lymphocytes in the gut than everywhere else, all right? So you can consider it as an immune organ. And so the salt activates a population of cells in there, producing IL-17, which is a cytokine. And this IL-17 gets into the circulation, and the cells get into the circulation, okay? So the IL-17 is circulating in the blood, gets to the endothelium in the brain, and generates a deficit of nitric oxide that the endothelium of the brain needs to regulate the diameter. So impairs the dilatation of the vessels. At the same time, what happens is that the circulating cells, they nestle into the meninges, into the coverings of the brain. And they produce IL-17, this time dumping it into the CSF, all right? That bathes the vessels. So you have IL-17 on both sides of the blood-brain barrier, essentially. Now, but the one that within the CSF activates the border-associated macrophages, who also have IL-17 receptors. So you have kind of convergence of two pathogenic factors, one acting from the endothelium by causing this deficiency of nitric oxide and lack of vasodilation. At the same time, you have the macrophages activated by IL-17 with production of free radicals. So you have a kind of this convergence of pathogenic factors that contribute to dementia. So if you, let's say, get rid of the cells in the meninges that make all this stuff, all right, you can make things better, all right? If you can silence the macrophages, chemical or genetically, you can make things better, you know what I mean? And so you can have this is a new, I guess, a new way to look at neuroinflammation as really a multicellular component that it requires, crosstalk from the meninges, to the macrophages, to the endothelium. So it's not just, the cell making radicals and everything goes bad, all right? But there is a very sophisticated signaling pathways that kind of work together. And this neuroimmune interaction is vital for the ARIA syndrome. So the amyloid-related imaging abnormality, which is a misnomer, because the patients not only have that, it's not just an MRI sign, all right? Not something you get by MRI, by imaging. The patient gets sick and they can die from it. Okay, like the last patient that was published in Nature Communication, who died of ARIA. So why is that? Because when you have a amyloid around the blood vessels, which is a risk factor for ARIA, all right? That leads to an pro-inflammatory state. So the vessel is already primed to be, tickled by these pro-inflammatory agents that are generated by the A-beta, amyloid-beta, which is pro-inflammatory. And one of the major target cell is the perivascular macrophage. And we've shown that if you prevent the association of amyloid with the macrophages by getting rid of the macrophages, you can make things better. All right. So the macrophage is there, affected by the amyloid in the perivascular space, as well as around the blood vessels with the CAA. All right, so amyloid angiopathy. Now, when the immunocomplexes formed by A-beta and the antibody that were given to the patient hit the macrophage, then you have the whole thing gets jacked up. Right? So you have more vascular dysfunction, you have more edema because the blood-brain barrier gets compromised, and that leads to hemorrhage, to edema in the good, in the best case scenario, which is called ARIA E. All right, or you can have ARIA H, which is hemorrhage, and these hemorrhages can be devastating. And two cases have died of brain hemorrhages. I mean, in both cases there were different circumstances, but in the first case, the patient had a stroke. All right. After immunotherapy, had a stroke and received TPA. All right, for the stroke, and then, but that obviously that was not the problem with TPA. It was the problem of the substrate in which TPA was being given. All right, in the context of a vasculature which was leaky and not functional. All right, so you're going to have. Yeah, the most recent case, I mean, the case most recently published, the patient was given heparin because had atrial fibrillation. Okay, so an anticoagulant, all right? Again, the problem was not the heparin, was the context, was the fact that the patient had already this ARIA syndrome, and that really led to a hemorrhage, a massive hemorrhage and death. So ARIA is kills people. So it's not just an imaging abnormality, but it's a disease, is an iatrogenic condition caused by antibodies to amyloid. Now, the interesting thing is that you can have ARIA also if you do not target A beta directly, but also if you target TREM2. Okay, so if you target TREM2, with these activated antibodies, you can increase the ability of the microglia to remove the plaques. Okay? And in that case, what's happening is that there is an amyloid overload all of a sudden. So the amyloid was sequestered in the plaques in the first place, all right? In a normal state. But when you have TREM2 activation, the microglia gets hyperactive, releases the amyloid, and the amyloid gets to the blood vessels and overloads the vessel. So that may be the final common pathway through which this ARIA syndrome can occur. So it's not as much as how you release the amyloid, all right? You could do it by TREM2, you could do it with the antibodies. It's because the excess amyloid being released from the plaques hits the vessel, which is already damaged to start with. And the vessel, this hyperinflammatory state induced by the excess amyloid will eventually, probably through the perivascular macrophage. That's our experimental data suggests. So we need to targeting these macrophages, which can be done now because there are sophisticated approaches to immunomodulate the cells. One may, perhaps in conjunction with the beta immunotherapy, you may also kind of silence the macrophage and decrease the ability of this ARIA to really cause problems. And ironically, the people who need it most are the ones who are going to suffer most from it. So the incidence of ARIA is greater in ApoE4 individuals, all right, which are the ones who need more, who have more Alzheimer, right? And this is a big problem because studies at the Mayo Clinic and in Japan have shown that with the criteria we have now, you could give the A-beta immunotherapy to less than 10% of the patients. All right, so you would make no dent on the Alzheimer, let alone the cost of the treatment. All right, who's going to pay for it? But it's going to be there's so many limitations now. And they will go, the more you use it, the more it's going to be used in the community. The more you're going to have complications because, if you have this complication in the setting of a very well-controlled clinical trials, where the patients are followed very, very closely by experts in the field, can you imagine when anybody is going to be able to give amyloid antibodies, what's going to happen, so you will have a much bigger problem. So it's important for us to understand and to devise, hopefully, ways to control that and minimize the the amyloid ARIA problem. There are ways in which you could silence ApoE4 in the so the macrophage is loaded with ApoE4 receptors, and so it makes ApoE4, and also is on the receiving end of ApoE4. So it's almost like a vicious circle, And so once you have inflammation, the whole thing gets upregulated, and you may have an exacerbation of that. So perhaps by silencing ApoE4 on the macrophages, you may be able to reduce the chances that you may have a complication from amyloid hitting the vessel.